We are so excited that so many of you elected to take time away from your busy schedules to join us for today's Ask the Experts webinar. My name is Ann Lloyd, and I am the Antimicrobial Stewardship Program Manager at Sanford Guide. I have the honor of sharing the platform today with 4 of our 9 editors, Dr. Douglas Black, Dr. Andy Pavia, Dr. Chip Chambers, and Dr. Michael Saag. I would like to share a little bit about each one of them with you. First, with Dr. Chambers. He is a professor of medicine emeritus at the University of California, San Francisco. He earned his undergraduate degree at Vanderbilt University and his medical degree at UCSF. His academic interests include antimicrobial resistance, genetics, molecular basis, and epidemiology of methicillin resistance in Staphylococcus aureus, staphylococcal infections, and tuberculosis. He joined our editorial board in 2007. Dr. Saag is a professor of medicine at the University of Alabama at Birmingham. He formerly was Associate Dean for Global Medicine and Director of the Center for AIDS Research at the University of Alabama at Birmingham. Dr. Saag is an internationally recognized AIDS expert and served as chair of the HIV Medicine Association, member of the IDSA Board of Directors, and served on the ABIM Board of Directors while he chaired the ID Subspecialty Board from 2004 to 2008. He joined our editorial board in 2007. Dr. Pavia is a professor of pediatrics and medicine at University of Utah School of Medicine in Salt Lake City. His interests have focused on HIV and AIDS and the epidemiology of emerging infections and vaccine-preventable diseases. He serves as co-chair of the Pandemic Influenza Task Force of the IDSA. He has served as a contributing editor since 2003 and has expanded his role in 2013 to fully cover pediatrics content. Dr. Black is professor of pharmacy at the University of Washington in Seattle, Washington. Doug's expertise is in the field of pharmacology of anti-infective agents. He joined the editorial board as a contributor in 2012 and is also the principal author of the Sanford Guide's monthly ID update newsletter. The objective for today is to answer your questions, and to do that, we have enlisted the help of our experts. Throughout this session, please use the Q&A feature to send us your questions. While we may not be able to answer every question, we will attempt to get to as many as possible. Finally, a recording of today's session will be available on our YouTube channel later. While we wait for you to share some of your questions, let's open the conversation by talking about some frequently asked topics and hot topics. So first, Andy, it's been a very active season for respiratory viruses this year. What new information is available regarding vaccines and/or treatments?
Thanks, Ann. Yeah, as you say, it's been a remarkable year. We've seen the highest numbers of flu cases and flu hospitalizations since 2009, which was a pandemic year. And interestingly, the vaccines actually worked reasonably well this year. CDC just released estimates from multiple different systems of vaccine efficacy for kids. Protection range, depending on the system, from 32 to 60% against medically attended flu visits. And for hospitalizations, as is often the case, it did a bit better. And it was 63 to 78% effective at preventing hospitalization. For adults, the numbers are a little worse, 36 to 54% for outpatient visits and 41 to 55% for prevention of hospitalizations. And that reinforces what we know about flu vaccines is they are moderately effective at preventing you from getting infected, but they have a much more important role in preventing severe disease and hospitalization. Obviously, we need better vaccines. The failures were mostly attributable to a relatively poor match against one clade of H3N2 that was circulating. The H1N1 efficacy was quite good. The other big story, particularly for pediatricians and gerontologists, is RSV, which hits people at the extremes of age, over 75 and under 2 are the people who have the heaviest impact from that. And this is the second year for which we have prevention strategies. What we saw epidemiologically was really interesting. We saw the year get off to a very slow start, but as we hit February, RSV continued to go up, and that's kind of unusual. We think that may be partially because of maternal immunization, protecting best those kids who were born in November, December, and January. So how are we doing with getting these new products, RSV vaccine and the monoclonal antibody, into people? I'd say we're making progress, but we've got a long way to go. CDC estimates that about 46.7% of adults over 75 and only 37% of people 60 to 74 who've got a serious medical condition have been vaccinated. So it's made a difference, but we've got a lot more to do. For kids, same story. We're making progress, but a lot of work to do. About 37% of pregnant women during the appropriate time interval were estimated to have gotten the RSV vaccine, and about 46% of infants born during during their first year of life got nirsevimab. So progress, but more work to be done. The other two diseases I want to talk about are Mpox and measles. So Mpox has sort of retreated from a lot of people in the US and Europe's mind, because what we're seeing right now is this enormous outbreak in Central and Eastern Africa. It's estimated there are about 21,000 confirmed cases of Mpox in the African regions. And it's largely due to clade 1, which causes more severe disease. Clade 1 has been seen now in the West, in Europe, in the US, in Australia, but so far small numbers and no sustained spread. The reason that we need to remind people about it is that when Mpox starts to spread, it spreads most dramatically among MSM, particularly those who've got a lot of partners. And during the previous outbreak, due to clade 2, a lot of people got their first dose of vaccine, but only about half of them went ahead and got their second dose. So if you qualify for Mpox vaccine and you got one dose, you really need to get that second dose in order to get lasting immunity. We've seen that protection fades. So lastly, let me talk about one of my other favorite diseases after influenza, and that's measles. And it's a favorite because it's so preventable and we've made such good progress. But this year is turning out to be really problematic. I think everyone knows we're seeing a large outbreak in Texas. It's still increasing at a rapid rate. On Friday, there were 142 cases in Texas. As of last night, there were 159. And then there are cases in 8 other states, although in the other states, we don't have sustained spread. And the reasons behind it are largely due to the drop in vaccination coverage, predominantly for children of school age and high school students. But we have a lot of unprotected adults out there, and about a quarter of the cases in Texas are among adults. Adults who get measles for the first time don't do very well. It's a miserable disease. I saw one of my friends, a surgical resident, get measles and be hospitalized for almost a week. So where are we? So, measles vaccination rates have fallen from about 95% nationally at kindergarten entry to 90.6% in the last data we have. But that doesn't tell the whole story, because we've got now 14 states in which less than 90% of kids enter first grade or kindergarten with measles immunization. So we've got these pockets of vulnerability, and West Texas has really demonstrated that. Last thing I want to say about measles is there is no treatment. I think everyone listening to this call probably appreciates that cod liver oil, clarithromycin, and budesonide are dangerous if given to a patient with measles, and there's no evidence that it's efficacious. So prevention is the treatment here for measles. So let's get everyone who's not fully vaccinated vaccinated.
Great. Thanks so much. We have some questions coming into our chat, and one in particular, which is one that we were planning to talk about anyway. And that question, let's start first with Doug, and then Andy might chime in too, which is, where do Sanford guide dosing recommendations come from? How do you decide the dosing recommendations that you put into the guide, and maybe comment a little bit about different populations in terms of dosing adjustments for us, please?
Sure, Ann. Yeah, thank you for the question, and thank you to the participant for the question as well. So let's just take a new drug. Let's say a drug gets approved today, and how would we go about approaching this? So when a new product is approved by the FDA, the base of data that we lay down in terms of dosing, and really a lot of things, comes from product labeling, and it's often not everything we need. Like if we were to focus specifically on recommendations for renal insufficiency, We'll usually have recommendations for decreasing creatinine clearance or estimated GFR, usually hemodialysis, but maybe nothing else. Maybe nothing for CAPD or CRRT, nothing for ECMO, those kinds of things. So we lay down the fundamentals with the product labeling. From that point forward, we follow the literature. And I think we all do this. Probably for me, my daily PubMed searches, which are automated, are really geared to reveal what was published, recently, yesterday, for all the drugs that might be on the guide. And I pour through those lists every day, and I look for stuff that we can use or that we should use to update these recommendations. And what you find is that eventually somebody will do some a PK or PD study to actually give us actionable data for CRRT. And we'll read those papers, and if those papers are of good quality and we trust the results, we'll actually put it into the guide. If they aren't, then we may note the existence of the publication, but go no further than that. And we'll also just follow the literature for changes in routine dosing, things that as resistance patterns emerge. And so there's this constant updating and evolution of the dosing. And our goal is to be as current as we can be and as evidence-based as we can be, and to make sure that our recommendations are things that people can use and trust. I think that same procedure is followed for most of the pharmacology on the drug pages. The recommendations for adjustments in hepatic impairment, or the recommendations for drug dosing and obesity, which is a really fluid area. And I look at that; those change all the time. And the fact of the matter is, a lot of the data are just poor. And you're trying to put together a recommendation based on either data you don't have or sort of data that's of dubious quality. So we do our best to do that. And I would say we err on the side of conservative in terms of recommendations. And the recommendations we put forward are things we can believe or we could justify to you if you were to reach out to us and ask about them.
And you asked about, how we come up with dosing for children. And it's a little bit more challenging there because, as everyone knows, children are not small adults. They have different PK parameters, and they change during childhood. So we scour the literature. We look at published references that are out there. There's Nelson's handbook. The AP puts out material, but it's understudied in kids, and that's particularly true for new drugs. Many new drugs do not have PK studies that go down into appropriate age groups. So we, again, and Doug does the heavy lifting here, we look at the literature, we think about the therapeutic index. So if a drug is very safe, like a cephalosporin, you want to avoid underdosing because there's very little risk of going on the high side. If a drug has a narrow therapeutic window, then you really need to be much more careful. The other issue that comes up with kids, and we get a lot of questions about, is do we have specific recommendations for dose adjustment for renal failure, for hepatic failure, for dialysis in kids? And that's a little bit different because in general, there aren't studies in children that we can go to, but the principles of how much your clearance changes when your creatinine clearance drops in half don't really change whether you're a child or an adult. You started at X, which is different for a child than an adult, but when your clearance drops in half, it's half of X or half of Y if you're an adult. So we do the best we can in an emerging field. If anybody has any influence on people going into clin pharm, we need more people to study kids.
Yeah, and I would add to that, Andy, also that, and for all the people listening, that these decisions are not usually made by one person, particularly for high volume drugs or for low therapeutic index situations. These decisions are often discussed among the editors, and we will make a decision based upon editorial opinion as well as all the published data. And that's important because for some of the questions we get and the things we wonder about, you just can't answer the question fully just by looking at publications. So you have to have some input from editorial members as well.
And I think we all work in, very fine institutions where we have a lot of really good, smart infectious disease colleagues. And that actually helps add to, the sense of what would you do in this situation when the data aren't perfect.
Perfect. One other question in this arena that I think we get asked on a pretty frequent basis that I hope maybe you could shed some insight on, Doug, is what about the difference between using creatinine clearance-based calculations versus glomerular filtration rate-based calculations for dosing adjustments?
Yeah, great question. It does come up. And, I guess what we try to do is provide recommendations based on whatever index was used for renal function in the first place. And the fact is, for most drugs and most antimicrobials, the recommendations were based on creatinine clearance estimations. And then recently, in the last 5 or 10 years, things have changed a little bit. And now we're seeing more and more recommendations based on estimated glomerular filtration rate. But we report what we know, and we report what we can justify. And there are simply many drugs for which we do not have what I would consider to be a trustworthy dosing recommendation for GFR. And what we do have is an accepted recommendation for creatinine clearance. And so we'll do that until we get the necessary data. And we also have a collection of calculators that I'm sure most users know about. And the most recent one that was included is an estimation of GFR based on cystatin C. So we're trying to keep up with the latest sort of evolutions of this and the latest predictors of renal function, and then work that into our recommendations when possible.
Perfect. Thank you both for those great answers. Let's jump back into another hot topic, or a topic that's had a lot of updates. And Mike, let's go to you and see if you could share with us any new updates for HIV this year, as well as I know there's been some news around the treatment of tuberculosis. So if you could share some of those updates with us, I think our listeners would really appreciate it.
Sure. So, as always, there's rapidly emerging data in the field of HIV in particular. Not like it was, say, in the 90s when we went through the heart revolution, but there still are a number of new drugs coming out. I think the recent ISUSA guidelines were published in December. They're referenced in the guide, so you can just go, if you're on the electronic version, just go and click, you can get right to it. And the HHS has been constantly updating their guidelines, and they're sort of in lock-sync. So that's kind of new information. I think the general rule coming out of that is that most initial therapies now start with a strand transfer integrase inhibitor, be it bictegravir or dolutegravir, supported with 2 nucleosides usually, although 1 nucleoside in certain situations can work, and occasionally with a non-nuc like rilpivirine. As you know, the bictegravir is a fixed dose combination with tenofovir alafenamide and FTC, so you can't really break that one out. But for dolutegravir, you can mix and match. The other trend that's happening that's very exciting is in the world of PrEP, the pre-exposure prophylaxis. And this is where especially long-acting drugs are having a role. Long-acting injectable cabotegravir, which is in essence injectable dolutegravir. That's a little bit of a stretch, but that's pretty much what it is. And that drug is, when it's taken, is remarkably effective in the 98th percentile of effectiveness. But the new drug that I think will be approved in the next several months is a drug called lenacapavir. Lenacapavir is a new class. It's basically it's not integrase, it's it prevents capsid formation and blocks it actually at 2 spots within the development of the capsid for the virus. But what it does, its pharmacokinetics is quite remarkable in that it allows every 6-month dosing with 1 injection. And so sub-Q administration of this drug is associated with, in one study, up to 100% efficacy, which is almost too hard to believe. But there's a second study that had a couple of breakthroughs. The bottom line is if folks can get on this, if they're at risk for HIV, lenacapavir, or for that matter, cabotegravir, are really good options because it doesn't require ingestion of a daily pill. That said, some people are okay with a daily pill. There's intermittent dosing, which is called 2-1-1 dosing of tenofovir, alafenamide, and FTC that can be given after an exposure, and it can be used also pre-exposure when someone thinks they're going to have a lucky night, if you will. They'll take 2 and then 1-1 on the 2 days that follow. And that was coming out of Jean-Michel Molina out of France that revolutionized that. So a lot of activity there, new drugs, the trend towards long-acting drugs. And finally, coming up, actually this coming week, is a conference on retroviruses and opportunistic infections, otherwise known as CROI. And that's taking place in San Francisco starting on Sunday. I've seen the preliminary program. There's a lot of really exciting data that's going to be presented there. I think what's really emerging in that field is actually still a continued focus on possibility of cure, using new approaches, not necessarily requiring bone marrow transplants, which was required to get a full cure historically. But I think we'll see new data about something called block and lock, and some other approaches that don't require the immune system to shut down the virus continuously, which is inflammatory. So a lot of work there. I think in summary about TB, the latest data are really about treatment of latent TB and shorter regimens. We were trained mostly with 9 months of isoniazid. Now there are ways of using rifapentine, and there's also, which can be done weekly for a 3 to 4 month interval. And then there's also shorter courses with INH and rifampin that can be used, again, for kind of a 3-month course. But all of this is in the guide, as Doug and Andy have already alluded. We are scouring the literature constantly for what's new and what's developing. Sometimes it's based on abstract data. Usually it's a published paper. But when new data emerge, this is pretty rapidly put into the guide, and references are provided. And that's one of the huge advantages of having the electronic version, be it on your phone or going to your perhaps hospital's internet or your home internet once you subscribed, that you can see these changes. Really, they're made by the editors and they're posted within a week or maybe less. And so you can get that right away. And as I mentioned, you can just click on a link and actually see the paper that supports the new recommendations. So I think that's a huge advantage over the print version.
Excellent. Thanks so much. Let's switch gears a little bit and let's talk to Chip about the spectra of activity. I think that is one of the areas that he works on the most. So Chip, can you talk to us a little bit about the Spectra table, which, if you're familiar with that, is the color-coded table that we have with organisms on one axis and medications across the top. Tell us sort of the intended use of the table, how it's been evolving over time, and maybe some of the limitations that people might think about when they're using that table.
Yeah, thanks, Ann. The Spectrum table, I think, is the most used resource in the guide because it's in a pretty friendly format that people are used to, or that's what we tried to do. It is actually a legacy document in a certain way in terms of how it came about from the original print version, although it's expanded at this point. And what it's meant to do is provide really a general, broad overview. It should not be used to make treatment recommendations. it should be used to get a sense of what drugs might work. And in the electronic version, which really provides the best flexibility and information access, each of the drugs and each of the bugs are linked to a particular page that go into details about what the specific regimens might be, and provides preferred regimens. The way the table is broken out with blue, we've had a lot of discussions about what colors should be used. Dr. Saag has attempted to be our color coordinator, but anyway, I won't say any more about that. Blue is preferred regimen. That's what would be the most recommended, our first line. Green are drugs that probably work or do work just as well, but aren't quite at the level of preferred most recommended regimens. Then we have a limited utility, which is a conditional use of a particular antibiotic. Maybe there's resistance in some locales that would limit it, or there's tox issues and that sort of stuff. Maybe the most, not controversial, but the one that's the trickiest is the not recommended group, because that reflects drugs that might have been used but now have fallen from favor, or have shown to have problems with emergence of resistance, or they're too toxic. Like, we tend not to recommend aminoglycosides because of toxicity, unless it's a preferred option, to give an example. So all of that goes into that table. But at the end of the day, it's a table, and it doesn't really give you specific enough information, and you need to go to the next step. One comment about what's in there and what's not, just to give a sense of that. You'll notice in the table that Neisseria gonorrhea is not mentioned in that table. Now, why is that? It's because when there are specific treatment guidelines that are based upon CDC or WHO or society guidelines, in which there are a very narrow group of drugs that would be used, it would be disingenuous to, like, we'd have one color, right? Maybe, or two. So that organism, and syphilis is another example, Treponema pallidum, is not listed in that table because there are very specific guidelines from CDC and other public health organizations. Then there are, for example, with Neisseria, we're talking about Neisseria, with meningitis, blood-brain barrier penetration is important. So a drug might be active in a test tube, but we wouldn't recommend it because of the meningitis concern. Or if we do, you may notice there are little carrots in the corner of some of these cells, and you can click on those. It'll give you additional information. But it is really the most basic guide that is not designed. It's designed to get you started and to provide options, but should not be used to decide what drugs to use.
One
Ann,
follow-up. Oh, go ahead, Doug.
Can I add one quick thing to that? So for those of you out there who teach, and that's probably everyone in some venue or another, to me, one of the most brilliant things about that spectrum table is the ability to make your own customized version. So like if you're teaching about urinary tract infections, for example, you can select certain microbes and select certain drugs and show that, and just show that. And for me as an instructor, I would do that and take a screenshot of that and make a slide out of that. And it's just a really great way to show, you don't have to show the whole table. Or if you're trying to teach somebody the difference between cephalosporins and how does cefepime differ from ceftriaxone, or how does levofloxacin differ from moxifloxacin, you can select simply those drugs, the microbes you want to show, and everything else goes away temporarily. I think if you haven't discovered that ability with that spectrum table, it's worth exploring, because it is at least for me. I'm a big user of the guide as well as a contributor, and I found that innovation to be just brilliant.
Thanks, Doug. One additional question I had about the Spectra chip that I think comes up sometimes is when a new drug comes to the market, How do you decide when it goes on the Spectra? And I guess when I say comes to the market, I mean sort of globally, because sometimes things hit different markets at different times. So how do we decide which drugs are included in the Spectra table?
We try and be as inclusive as possible because we do have an international user base for sure, which is pretty significant. So to give you an example, Istria, a monobactam antibiotic, which is basically pure gram-negative drug, has been in the Spectrum table for a while. Well, Istria avibactam is now approved outside the United States in certain locations. So we added that. And it has a little bit different spectrum because of the avibactam. We added ceftobiprole is now approved in the United States, although not available. But when that drug becomes available and has a significant user base, and by significant, we mean that it is available in more than one or a handful of countries, that it's generally available through EMA, through the FDA, through Asia Pacific, that it's reached some level of usage, we'll add that drug.
Perfect, thanks. All right, let's switch directions for a bit and let's talk about duration of therapy. So as someone who is an antimicrobial steward, duration of therapy is something that, we look at a lot when we're trying to optimize antibiotic regimens. And so Mike, I was hoping you could maybe comment, and we could ask this question a bit, like how should duration of therapy be determined? Is it based on the organism, or are there other things we should think about that you might want to share with us?
Sure, and I think this really boils down to principles of infectious diseases being applied in the real world setting. If you think about it, there are very few diseases for which there was a prescribed you give for X. I think infective endocarditis is probably the one that we think of the most. 4 weeks native valve, 6 weeks prosthetic valve, and that has been sort of the dogma in the field for years. But when we pull back and ask the question independent of infectious endocarditis, what are we looking for? The bug matters because some bugs, like latent TB, that doesn't replicate that often, but drugs that are rapidly multiplying, the drugs oftentimes have a better chance to work. The location, where is it? Is it at a site that's easy to access for the medication? Does it penetrate into that tissue well? Or like the meninges or perhaps bone, especially when there's sequester present, they may not penetrate as well. So bug, location, source control. Has the infection been drained if it's an abscess? Is there evidence that now the drugs have an opportunity on a clear battlefield to go in and take out the enemy? And then another key thing is tolerability, toxicity, those things come into play. And as we know, the longer we treat, the more likely there's going to be a toxicity. We worry about C. diff infection and that type of thing as a consequence of antimicrobial therapy. So you put all this into a cauldron and you come up with an estimate. One of the sayings that I like is that you can only kill the bugs once. Once they're dead, they're dead. And so if we have a situation where source control has been achieved, there is a location that is not hard to penetrate with the medications, the bug is quite susceptible. That's a part of the bug issue. Is it susceptible or is it kind of quasi-resistant? But if it's susceptible, rapidly replicating bug, then shorter course really is the way to go. And a lot of research in the last 10 to 20 years has really focused on shortening the course. And for those of us who trained 30 years ago, 40 years ago, we're not used to this. We think, you use 14 days for pyelonephritis and that type of thing. And those things have changed. And so what we're trying to do with the guide in the last 10 years or so, maybe 15, is to really help provide guidance for antimicrobial stewardship, the use of antimicrobial therapy in such a way that we maximize the impact of the drugs and minimize their their toxicity and long-term impact. There's no reason to continue a medication once it's done its job. Another analogy that I use, especially on wards when I'm teaching, is to say that I like to use a military analogy that antimicrobial therapy doesn't really, you're not curing anyone. The body's healing itself. And so what we're doing is helping the immune system clear the infection away and giving air support for the infantry. We can't take the hill with air support alone. We need infantry. And that just reminded me of the fifth factor that I forgot to mention is the host. Is the host immunocompromised? Are the white cells working? So if you have a host that's in good shape and has got a good immune system, shorter course can work. If you have a host that has lost their neutrophils from chemotherapy or other interventions, then you're going to need longer therapy to cover the bugs until the immune system recovers. So air support for the infantry, minimizing toxicity when we can, and shorter course becoming a key factor. I know that maybe Chip, Doug, or Andy may have other things to add to what I said, but that's generally the concepts.
Yeah, Andy, I think you're on mute.
Sorry, I wanted to emphasize what Mike said about the emerging data. It was, 20 years ago, not considered a worthwhile thing to do clinical trials to compare duration of therapy because we had football scores of 7, 10, or 14 days that we followed. And there's been a whole raft of clinical trials, as well as very well done retrospective studies that use state-of-the-art adjustments for confounders that have looked at duration of therapy. So we have really good data for things like community-acquired pneumonia, for most ventilator-associated pneumonia, for complicated and uncomplicated UTI. And in most of those studies, shorter was better. As a tagline, shorter is better isn't 100% true, but the majority of studies have supported that. So on the duration page, we try and reference the data when it's out there and when it's really clear. And there are areas where we clearly have to move what we're doing and the stewardship we're doing to the shorter durations.
Andy, are there any pediatric considerations that are different, or how is the data different for pediatrics in any of these duration, controversies?
Well, in pediatrics, often the issue is where do we have data gaps? So we don't spend as a country enough as much money on doing clinical trials in adults. So we often extrapolate down to kids, or we do good, high quality comparative effectiveness studies because we don't have a clinical trial. And often we have data down to some age range like 2 or 1. And below that, you have problems with an immature immune system, different PK. And so it's hard to take a study that was done on, let's say, ventilator-associated pneumonia, in which we have data that pretty much covers the age range from 2 to 100, and extrapolate to the NICU. And we try and, when we know that, we try and give some guidance on that. That said, I'll bet if we did the clinical trials in the NICU, we would probably be shortening some of our durations of therapy.
One more thing sort of in this same topic area is what about using oral antibiotics to complete courses of therapy? So I know maybe Chip might have some thoughts about that. Doug maybe has some thoughts about, IV to oral conversion. So kind of just open it up for some thoughts about using oral therapy instead of IV.
Yeah, Doug, I'll take a shot at it and then you can add color commentary. Bacteria are pretty smart. They know how to avoid our drugs through resistance, but one thing they do not know is the route of administration. So if you can give a drug orally and it has sufficient bioavailability, and the pharmacology and the pharmacodynamic principles are achieved, there is no reason other than the patient taking the medication, which is a big other than, oral therapy should work. Now, there are several practical considerations. Oral therapy 6 times a day is probably not not a winning formula, right? So it needs to be a regimen that can be complied with, which means once, twice daily, maybe 3 times. When you start getting 3 times daily, you're pushing the envelope. But on first principles, there is no reason, as long as the drug is absorbed, why oral therapy should not work just as well. Obviously, with IV parenteral therapy, you can get much higher levels much sooner. And so I think for most serious infections like bacteremia, you would want to have confidence that you've eliminated drug delivery as a concern, so you would start with parenteral therapy. But once the infection has been brought under control, assuming there is a viable oral regimen, and you'd like to see some data, right? There's the POET study on endocarditis. We just looked it up for one patient. The problem with that study is if you're talking about oral therapy of staph bacteremia, for example, there are 40 patients who received oral therapy in that study who had left-sided endocarditis. So, you know, certainly it's an option. You'd like to have a larger experience if possible, but slowly, I think, as we see it as possible, it's moving in that direction. Doug may have some other things to add.
No, not really. I mean, you know, we're fortunate to have a lot of pharmacokinetic, pharmacodynamic data out there to help guide us with this. But at some point, you need clinical outcome data as well. And you know, those are the kinds of things I think that cause us to make more formal recommendations in the guide. But we do try to provide the PK/PD data that's available for people so they can make their own decisions in certain circumstances as well.
And I'll add that, you know, I've been complaining about the lack of data for children, but in pediatrics, we're actually a little bit ahead in terms of studying IV to oral switch. And we've been doing that for a while, and now the standard of care has shifted that anyone with any child with hematologic osteomyelitis is transitioned to oral therapy after initial response. Same thing is true for bacteremic pyelonephritis, community-acquired pneumonia, empyema. When you've got a drug that's bioavailable that the patient can take, that you can give. And I'll add one thing, you know, I was taught long ago, you can tell by the color of my beard that was a while back. That's, you know, Keflex, cephalexin wasn't a very good drug because it achieved such low levels. And in large part, it was because we were giving these almost homeopathic doses. You know, kids were getting 25 to 50 milligrams per kilogram per day. And with doses of 100 to 150 milligrams per kilogram per day, we can treat serious infections with cephalexin that we thought could not be treated. And it's, of course, well tolerated and acceptable dosing intervals for kids.
Perfect. We've got some more questions coming into the chat. So Doug, there's one here for you about continuous infusion of different antibiotics. Any comments about continuous infusion of vancomycin or beta-lactams? Thoughts on when those strategies might be used, and any considerations in patients that have renal impairment?
Yeah, I'm reading that question, and the second part of the question, what other antibiotics like beta-lactams, is it justified for empirical use or only when a specific microorganism or MIC is isolated? Yeah, I think continuous infusion may make a lot of sort of logical sense from when you look at the pharmacodynamic behavior of a drug like a beta-lactam. But there are practical matters involved in terms of tying up intravenous access and for the entire day, or issues with compatibility. So I think as an empiric recommendation, I think most of the time a continuous infusion beta-lactam regimen probably isn't something most of us would do. But in circumstances where one needs to maximize a beta-lactam, for example, a high MIC microbe, and if you've got the ability to do it with all the other things going on with the patient, then I think on a case-by-case basis, it's worth considering. And then the first half of the question was specific about vancomycin, and the question phrased, is it an actual good strategy? I'm just struggling with, I don't know if it's a good or a bad strategy. I mean, it is a strategy in patients with renal impairment. I mean, I'm thinking about a drug with a 250-hour half-life in renal impairment. So, I don't know that good or bad is necessarily question, I mean, I don't know how much is gained by giving vancomycin by continuous infusion to somebody with renal insufficiency. I mean, it's a drug that's easy to dose by and monitor with continuous infusion by simply measuring the steady state level and multiplying by 24 if you're looking at AUC. Yeah, there may be a circumstance where it makes sense. But, again, we have these compatibility issues and convenience issues to mention. And I would also add that sometimes it's hard to determine what the pharmacodynamic target ought to be. I mean, if you look up in various references, references will list some percentage of the MIC of the dosage interval that the MIC concentration has to be above the MIC of the pathogen. But is it 40%? Is it 50%? Is it 4 times that? What is it? It's hard to get a clear answer to that question sometimes. And without a clear answer to that question, it can be hard to then justify these more novel routes of administration. So I would just say that I think they're out there. They may make sense in certain circumstances, and we will recommend them when they make a lot of sense. But in a lot of circumstances, they don't really gain you much.
Yeah, I would say it's more a question of science or religion than hard data in most cases. And for more seriously ill patients, maybe there's a benefit with a marginal MIC, but there's a number of practical considerations that limit it, sure.
And there's also an art of medicine aspect to it. So for people who have to go home on vancomycin, children have to go home on vancomycin, depending on their age and their activity level, we may use continuous infusion so that they can be connected the whole time through the day when they're at school. So we can recalculate the dosing with a single drug level. And sometimes it's really convenient. Small pump under the clothes, and the kids actually like it.
Great, thank you. One more question that I have, and then we have one more user question, and then that might be all we have time for. But this question is for Doug, and it's about the pregnancy risk categories. When I was in pharmacy school, we learned A, B, C, D, and X. And over time, that has changed. What happened to those categories? What are the recommendations now for interpreting the literature about using antibiotics or anti-infectives in pregnant patients?
Yeah, great question. I think probably all of us on the call were taught that, the A, B, C, D, and X classifications. Yeah, I mean, I think what people realized was that, among other things, people were using those categories as kind of a simple way to predict the safety or the appropriateness of using an antimicrobial without really understanding the underlying data behind those recommendations. So in 2015, things changed, and the FDA did away with those A, B, C, D, and X classifications for newly approved drugs from 2015 onward. And now we have a narrative. And if you pick up the product labeling, you'll see section 8.1, section 8.2, and 8.3 of the product labeling. And these are narratives that give you in words what we know in terms of animal toxicity, human toxicity, and human data for the use of these drugs in pregnancy. And there's no longer a letter. And then there's also a separate section 8.2, which is a better description of safety during breastfeeding. And there's a third section 8.3 that provides even further recommendations in certain circumstances. So they've gone away, but the part of the decision was, what are you going to do with drugs that were approved 20, 25 years ago? And so there's this slow changeover of older drugs to the new system. Past 2015, they all have to be via the new system. Before that, it's being slowly phased in over time. So we're trying to keep up with that stuff in the guide, and that often simply means pulling new product labeling or looking at LactMed. LactMed is a great resource for drugs and lactation, by the way. A lot of our recommendations for breastfeeding come from LactMed. So we're all kind of living through this transition, but that's where it started in 2015. I think it is an improvement because it does give prescribers and healthcare providers a better understanding of really what we know about safety of a particular antimicrobial in pregnancy.
Perfect. Thanks. Okay, so one more question that I had on our list of questions goes back to Sanford guide. We obviously have digital products, and we've talked a lot about our digital products, but we started out as a book. So what's the difference between, there we go. What's the difference between the book and our digital content? How do you decide what goes into the guide? And then, again, how should people approach the two different tools besides moving towards the digital product? How should they approach using the book versus the digital product? And I'll just open that up to whoever might want to take a stab at that one.
I'll take a shot at it. As all the editors know, I shouldn't even say this, but I'm going to. I am not a fan of the book. Okay. Here's why. The book is updated once a year. It is out of date within 1 month of its publication for at least some category, right? And in the book, there will be columns and rows, and there might be, 4 square inches of real estate. In the web or the app version, there's as much real estate as can be digested. So there's a whole lot more nuance and accessibility. And then I haven't really cited the real reason. The print's too small and I can't see it now. So the book just has a lot of limitations. I understand it's handy if you don't have a phone, but everybody's got a phone now. It's the digital version is updated on a regular basis, pretty much weekly. There will be a change. In terms of topics, we add topics. We've probably added 10 or 15 topics in the last few months that will be in the digital guide, based upon queries from our users or new information that's available. So it's really about currency, accessibility, nuance, volume, linkage to references. It's just so much more facile resource.
Yeah, I'll pile onto that a little bit in that it's everything Chip said, but the real estate is a big deal because you can only say so much per column or row of a table when it's limited. Even if you can't read it, it's still limited. But in the electronic guide, there's a lot more content about setting the stage in terms of background of the entity that you're talking about, a little bit more about diagnostic, a little bit more, the etiology is fine, but then the treatment has even more nuance to it. And then the comments. So you've really got, and then stewardship, the duration that we just talked about, is often have a segment there that doesn't translate well over to the print copy. So, I don't think there's that much of a cost differential. My guess is it's about the same. And so if you're going to put the money, then you have this with you, all the time when you're on wards. You have to remember to bring this. And look, it's gotten so thick. You got to start walking, listing to one side to the pocket that it's been in. So I can't say enough good things about the electronic version.
Yeah. And
having trashed it, though, I will say that we still put effort into it, right?
Yeah, sure.
This is not benign neglect. It's just the limitation of the medium.
Yeah. And I'll pile on too. I mean, there's my vote. But as a teaching tool, when you're on the wards, it's just so much more valuable. You can move from the disease entity to the guidelines. You can pull up references. You can pull up the calculators and show the residents how you're coming up with doses or how you figure out somebody's creatinine clearance or their ideal body weight. So it's really so much more flexible. You don't have to go scrolling through if you want to find some specific details about CSF penetration. You go from the disease to the drug, right down to the data on the drug page.
Yeah, and Ann, we can enhance the searching, right? For and or not searching on the search bar, which is really great because at one time when you tried to find information electronically using the search bar, you would put in a term, say daptomycin, you would get every single page that had daptomycin on it. But now you can do daptomycin and something, or daptomycin and something, not something, and really hone down your results. That just makes finding stuff even faster. It can be difficult to find what you're looking for in the print guide. Even if you can see it, it can be hard to.
And as everyone knows from using EMRs, user interfaces get better if you can get feedback. So if people have comments about the user interface on the app, we'd love to hear it, because we're always looking for ways to improve it.
And maybe that's a good way to kind of wrap this up before you wrap up, Ann. But the beauty, one of the coolest things about the Sanford Guide is the ability for the editors to respond to user inquiries. And encourage you to send in comments. It hopefully will be helpful for you, but I can tell you that it's helpful for us. One, as Andy just said, it helps us on the design and the accessibility, but it also helps us keep the guide current. Sometimes we've overlooked something. Sometimes something is a little bit outdated and we didn't update it to the latest literature. Bring that to our attention and we'll get it turned around right away and send you back a comment on what your question stimulated and what the outcome was. So please talk to us, let us know what you're thinking. And that's another indirect service of the guide, not only for people who wrote the question, but for the guide itself. It's a QA function that is really helpful.
Perfect. You were right. That was a great segue into our closing. We really would like to thank all of you, Drs. Black, Pavia, Chambers, and Saag, for sharing your expertise with us today. We also want to thank all of our attendees for joining us. We really hope this webinar has been informative and has enhanced your understanding of the topics we have covered. As mentioned, we would love to hear your feedback on this session and get your ideas for any future sessions. Please reach out to us via email at stewardship@sanfordguide.com, or you can also connect with us through the app or on our website and give us your suggestions. While we may not have been able to answer every question today, we attempted to get to as many as possible. And a recording of today's session will be available on our YouTube channel coming soon. Thank you all again.